You there?
Yes, sir. Right.
So let's start. Okay. So sorry for the delays for some technical issues. So today, thank you very much everybody who has joined this webinar. Today we'll be talking about the tips and tricks of the VATS esophagectomy. We know that this is a very complex surgery indeed, and we need to know a lot of things about how to proceed during the surgery and also how to tackle the post-operative complications. That would be the most challenging and important part. So let's review some of the things. So my overview of presentation today will be to define the principles of esophagectomy and how the minimally invasive esophagectomy evolved, a concept about the multimodality treatment, and evidence in favor of the minimally invasive surgery, the technique, intra-op complications, post-op complications, future perspectives, and key messages. So let's start first of all with the principles of esophagectomy. So indeed, it consists of the resection and reconstruction. The morbidity should be less than 40% and mortality indeed should be less than 5%. And the patient should have a good quality of life. So it can be further subdivided into transthoracic esophagectomy, transhiatal, or extended total gastrectomy. Transthoracic has also several parts, so I will be not talking much about this. The open can be done or the minimal invasive way. The minimal invasive, we can do the VATS laparoscopy, the hybrid approach, the robotic approach, and uniportal. So this slide, this chart shows very well how many types of the surgery exist for the resection of esophagus. So we can have a lot of open approaches and also a lot of minimal invasive approaches. So the evolution wise, first of all, it was started from the left thoracotomy. So we can see here, this gentleman was a great surgeon, Frank Turek. In 1913, he performed first of all the first esophagectomy through the left thoracotomy. So it was the picture. He made a bigger incision in the left side of the chest, and he did the gastrostomy and esophageostomy in the neck. And the patient used to combine a rubber pipe. He used to swallow through the mouth, and through the tube, it used to go inside the gastrostomy. And later, when the surgeon got more confident regarding the surgery, then he convinced the patient, let's do the reconstructive surgery. But the patient refused because he survived for 13 more years and then he expired for some other reasons. So I think this approach was a very classical approach in those days, 1930. What is very important at this point of time is the principles of minimally invasive multimodality treatment. So we should go for the multimodality treatment. We should always, most of the time, we go for the multimodality treatment because in our parts of the country, a lot of patients are coming not in the early stage but in the locally advanced. So how we define the locally advanced disease? So anything which is more than T1B, it means anything which goes beyond the submucosal layer, and anything is more than N0, it means N plus, N1, N2, N3, N. This category of patient requires the multimodality approach. So a Japanese slide very well shows we should have a very good diagnostic regarding the depth of the tumor, nodal metastasis, and indeed the distant metastasis. On that background only we can decide what therapeutic approach the patient requires. So just coming in brief regarding the principles of multimodality treatment. So we can see here in the multimodality treatment group, we define this for the squamous cell carcinoma and also for the adenocarcinoma. So I have just only formalized few of the landmark trials which are very important for the esophageal surgeon to know about. So for the squamous cell carcinoma, it is the cross trial. Just a second, sir. So it is a cross trial, which is the landmark trial for the esophageal cancer that I have mentioned is the cross trial. There is the Japanese trial, there is the JACO 1109X trial, and the checkmate, because this is the era of immunotherapy and esophageal cancer is not away from the immunotherapy. For the adenocarcinoma, again, this cross trial comes true. Then comes the flow trials, and indeed there is the checkmate trial also for the adenocarcinoma. So coming just in brief regarding the cross protocol, it was started with the weekly carbo and paclitaxel concurrently with the radiation therapy, which was given up to the dose of 42 gray, 41.4 gray, and the surgery was done 4 to 6 weeks after the completion of chemoradiation. Indeed, the reassessment was done, and if there was the responder, then the surgery was planned afterwards. So in this group, we can see for the squamous cell, can you mute the sound, please? Can you mute the sound? Yeah.
Sound.
Can you Yeah. Yeah. A lot of echo. Please mute your sound. Yeah. A lot of echo. A lot of echo. A lot of echo. A lot of mute all. Mute all. Your question for mute then. Yes, okay. So am I audible now, Dr. Kumar? Am I audible? Okay. So coming to the cross protocol again, we see the complete pathological response for squamous cell carcinoma is up to 50%. It means every second patient after chemoradiation has the complete response. Whereas for the adenocarcinoma, it goes up to 23%. It's also very remarkable indeed that after cross protocol for squamous cell carcinoma, every second person has got the complete pathological response. So now going just afterwards, so this is the 10-year outcome of the neoadjuvant chemoradiation according to the cross protocol. It shows that whoever has gone this as per the cross protocol, it has very good 10-year over survival in comparison to the only single modality surgical arm. So right now, this has become a standard practice for squamous cell carcinoma. So this was the conclusion. Coming to the float protocol, it was basically designed for the adenocarcinoma of GE junction of the distal esophagus. So it starts with the 5-FU leucovorin oxaliplatin and docetaxel. The combination is the 4 chemotherapy before surgery, 4 cycles, then surgery, and afterwards the 4 cycles of adjuvant chemotherapy. So this trial was basically designed to compare the ECF or ECX regime, which was the MATIC trial, which was the one's standard practice. But later on, the float trial had the better results. Therefore, it became the standard practice for the neoadjuvant treatment of adenocarcinoma of the distal esophagus and GE junction tumor. So these are the charts which show the same things. Now, there is a very contradictory point. I mean, the Japanese do not believe much in the chemoradiation. They say that you have to, if you need to treat the patient, either go for the surgery or go for the chemotherapy. Don't mix together, I mean, the chemoradiation together with the surgery, it may be not very beneficial. So according to their logic, they have come up with the results of the JACO 110 trial, 9 trial, that's the next trial. They have got a good number of samples, that's the 600 patients. So they compared the classical CF regime that consists of 5-FU cisplatin versus DCF regime, that is the docetaxel cisplatin and 5-FU. And later he also had, according to the cross protocol, this is the CFRT, not cross protocol, this is a cisplatin 5-FU and radiation therapy. And they found the survival was equivalent, even better for the DCF in comparison to the CF regime, and it was almost equally equivalent to the chemoradiation protocol. So in Japan right now, they say that for the stage 2nd and 3rd clinical stage, esophageal and GE junction tumor, the DCF, squamous cell carcinoma, sorry, the DCF regime is the standard practice in Japan. So they have been practicing this approach. So there was another trial, NeoAegis, which looked into the matter. So if for the adenocarcinoma, if we compare the FLOT4 regime, this one, versus the cross protocol, mind you, it's for the adenocarcinoma of the distal or GE junction tumor. So for this category of the patient, this NeoAegis trial showed there is no obvious difference whether you do the period of chemo as per the MAGIC or FLOT protocol, or with the tri-modality treatment, including the cross protocol. So the survival results are almost equivalent. So it's our right, it's our choice, which kind of the treatment we select for those kind of the patients. So we're equally true and equally correct if we choose one option versus other option. So now coming to the checkmate trial, so now every solid tumor has got the immunotherapy in the armamentarium. It means either we start in the neoadjuvant protocol and that's when setting. So the nivolumab has come up with good results if we attach with it, combine this in the postoperative period. So it has been said that adjuvant immunotherapy after neoadjuvant chemoradiation surgery, it was the checkmate 577 trial, and they defined it. We can see here, the nivolumab group has far more longer survival results than the non-nivolumab or only the cross-protocol patients. So they recommended, so for the locally advanced tumor, like T14, N0, N plus patients, we start with the induction chemoradiation as per cross-protocol followed by the surgery. Then if there is complete pathological response, then we can keep the patient under surveillance. That's a very logical practice. But if there's the residual disease, then we follow the patient, we provide the patient, those patients with the immunotherapy. Beforehand, we're not quite sure after induction chemoradiation if the patient had residual disease and surgery was done, what to do. There was a lack of any evidence. So now immunotherapy has become the treatment of choice in this category of the patient. So this has been published in the New England Journal of Medicine. So that was a checkmate. So now there is a great debate between, there's great difference between East and West, whom to follow. For us, I mean, we are from the developing countries, we don't have a good practice guidelines, so we should follow either the East or West, or we have to be in between them in a win-win situation. So it is the classification TNM for the squamous and adenocarcinoma. As I've compared it, this one, this two side has shown the most of the patient to us coming in the stage 2 to 4A. They are still resectable, but in those categories of the patient, we shouldn't do surgery upfront. We have to add some of the pre-operative treatment, either in the form of chemotherapy or chemoradiation, as per our justification, as per the guidelines we believe in. So this was the practice guideline for esophageal cancer, edited version, which was from the Japanese Esophageal Society in 2022. It was published. A lot of confusing figure here, but they said basically the same things, that if it is the surgery, if the patient can tolerate surgery, surgery is the best option for the initial disease, for the early stage. If it is the locally advanced, then we have to add chemotherapy. That is their personal choice. But chemoradiation, as per the NCCN protocol or the CROSS protocol or the European Society of Medical Oncology protocol, but they generally stick to the neoadjuvant chemotherapy as per the Jacob 1109 trial. So this is the same thing has been shown. And the NCCN guideline, if you look into the NCCN guideline for the squamous cell carcinoma, for the earliest stage, we can do the esophagectomy. But for the latest stages, I mean, for the locally advanced stages, they always start with some sort of neoadjuvant treatment. It is the guideline from the NCCN and also the European Society of Medical Oncology. So summarizing this part, we can say that in the multimodal treatment for the squamous cell carcinoma, we can choose one of these versions, either the CROSS protocol, neoadjuvant chemoradiation, or Japanese protocol according to Jacob 1109, or the checkmate protocol. In our part of the world, in our country, the nivolumab is very expensive. I don't think much of the patients, many of the patients can afford for that. So we have to select either in between the CROSS and Jacob. In our institution, the practice is that if the patient gets early date for the radiation therapy, then we always prefer for squamous etiology as per the CROSS protocol. If the waiting period is too long, then we consider for the JAK protocol is quite convenient and evidence-based practice. For the adenocarcinoma in our institution, we always select for the floor for protocol. We don't go for the CROSS or checkmate because of the financial constraints. So now let's see about the evidence of minimally invasive esophagectomy. In the early time, this was the picture taken, I think, perhaps 20 years back in my early career when I used to do the open surgery. So you can see the open surgery was also very good. This is the tumor was located in the middle esophagus. We can see the trachea, it's here, the trachea. This is the right main bronchus. This is the left main bronchus. Everything is clear very well. All the lymph node dissection was done very well. This is very clearly seen in the open surgery also. This is again the same picture, very clearly seen. This is the recurrent laryngeal nerve left, if I can show here. This is the trachea, very well seen. This is the left bronchus, even the right main bronchus, upper lobe bronchus, truncus intermedius, everything is seen very clearly, even by the open surgery. But this is very traumatic for the patient, very painful for the patient. It takes a longer time to make the incision and close the incision. Again, it's showing how we can dissect the right recurrent laryngeal nerve here, and the left recurrent laryngeal nerve was shown here. So everything can be done by the open surgery also, but very painful for the patient. So later on, we changed our practice. So there are a lot of evidences also. The Miro trial was there, which was in favor of the minimally invasive esophagectomy. There was the time trial, which also favored the oncologically, the minimally invasive surgery is not inferior to the, in some constraints regarding the blood loss or early outcome, even minimally invasive surgery was better than the open surgery. So now the concept of lymphadenectomy is also one of the controversial points. If we go to the literature, what does the Hulser, what does the Oringer say? Even the Hulser says there was a randomized trial Hulser group, and they said that for locally advanced disease, there is no difference whether we do the minimal surgery like transhiatal esophagectomy when we don't pay much attention to the lymph node dissection, or we go for the extended lymphadenectomy. like whole mediastinal lymphadenectomy, 2-filled or 3-filled, there is no difference. So this depends upon the philosophy of the surgeon, what he thinks, how does he take the esophageal cancer. So 11th edition Japanese classification is very good. I think for the residents, they have to know about this one. Esophagus divided in these 3 parts. So there are a lot of lymph node groups according to the Japanese Esophageal Society. And I think we should be following this. I personally, in our institute, we follow the Japanese Society guideline for the esophageal cancer station distribution. So these are the groups, N1, N2, N3 groups divided for cervical, upper, middle, and lower abdominal esophagus. You can get this one from the literature. It may not be very important to discuss all these points. So these are the pictures which show for which group, regarding, for example, for the middle group, which nodes have to be taken out. So these are the groups which are mostly involved by the tumor. So indeed, those lymph nodes have to be taken out for both better staging and possibly for the better treatment survivability of the patient. So this was this, as per the similarly, like the gastric cancer, we have the D2, D3, D1, D2, D3 dissection. For the esophageal cancer, also we have this kind of dissection. If we do the 2-fill, there is the D2. If we do the 3-fill, there is the D3 lymph node dissection according to the Japanese protocol. So lymph nodes, we have to find out during the CT scan as well beforehand. How do we guess? We don't count the number as advised by the NCCN. If the number of the lymph nodes less than 2, then N1, how we have to count the number of the lymph nodes. So one of the factors could be either the PET scan, EUS, and for the smaller nodes, it may not be picked up by the PET scan also. So there can be several parameters which we can define by the CT scan as well. So that will take into account the structure, aqueous structure of the lymph node, the intensity of the enhancement by the contrast, the cell, oval shape or round cell, etc. There are certain features which can be taken into account for the CT-wise classification or prediction whether the lymph nodes are positive or not. So these lymph nodes can be very well defined in the CT scan. If we take the DICOM files and study. So in our institution, we also have started the practice of reviewing each and every patient's DICOM files before taking the patient for the surgery. So that we must know which lymph nodes are possibly suspicious for metastasis, and those lymph nodes have to be taken out anyway during the surgery. If we're leaving behind those lymph nodes, the surgery should be considered incomplete. So these are some of the CT pictures which we can define where lymph nodes are present or where the lymph nodes are absent. So the technique, now coming to the next point, is the technique. This was the theoretical background, what we do for the minimally invasive, regarding esophageal cancer as such. So first start with the positioning, then the infrazygous dissection, the suprazygous, the TME, that is the total mesoesophageal excision, as per the concept of the total mesorectal excision for the rectal cancer. The complete 2-fill lymphadenectomy, the thoracic duct clipping, the lap gastric mobilization, cervicotomy, and esophageal anastomosis, and the feeding jejunostomy. So this one of the pictures very well shows the diagrammatic representation. So this is the azygous arch. Here should be the superior vena cava. Here lies the esophagus, this one. So we start with the infrazygous, going here. So we start like this and go beneath the azygous, the dissection of the esophagus. So this way. Then afterwards, we go for the supraazygous dissection. So go for the supraazygous. If you wish to clean the recurrent laryngeal nerves, we can clean in the supraazygous dissection. There's a small video how we do in our setup. The esophageal, the minimally invasive esophagectomy. This is a semi-prone position that we select in our patients. We generally put the 3 pores, sometimes we wear the 4th pore if necessary, in the 5th and 7th and 9th intercostals. But this is the diagram, how we proceed. So we generally use only hooks, sometimes the bipolar instrument. There may not be the need for any high-tech devices like ligature or the harmonic for the esophageal cancer mobilization. For the lab part, yes, we need that, but for esophageal chest part, we may not require. So this is how we make the pleural incision just in front of the esophagus. This is the esophagus, this one. So in front of the esophagus, beneath the azygous arch, we're making dissection till we reach the diaphragm. This is the diaphragm, and this is the right cross of the diaphragm. So we go up to that. We can see the flimsy layers. So we call it, this is the esophageal tumor. We're making a distance. We should remain at least 3-4 as much far as possible from the tumor, so that we can call it the mesoesophageal dissection. It means a tissue further beyond the esophageal envelope is being cleaned. in order to achieve a wider artery resection. In chest cavity, we cannot take as much tissue as we wish because of the very important structures that are located in the chest cavity, like aorta, like heart, like trachea. So it may not be possible for us to dissect all these structures, wider margins. So this is how we go for the infrazygous dissection as shown in this picture. I will forward a little bit. Then we go for the suprazygous dissection. This is the zygous arch. It's up to your preference. In earlier days, we used to divide the esophagus arch. Right now, we are not dividing it. If necessary, if it is involved by the tumor, if there is some lymph nodes which are lying just beneath the esophagus arch, then you may need to ligate it for your convenience. Otherwise, it's not essential. This is the trachea we can see here. This is the trachea. This is the left border of the trachea. So this is the left recurrent laryngeal nerve. So we can clean. We should be very cautious in this part of the dissection with the cautery because you may dissect. So whole of the recurrent laryngeal nerve is seen here, can be taken, and the lymph nodes are generally located. I don't know how the God has created this view, but the lymph nodes go along the recurrent laryngeal nerves. That was the right recurrent laryngeal nerve that I showed there. So at the end of the surgery, our practice is to clip the recurrent laryngeal, the thoracic duct. So it's very good habit to preserve the right bronchial artery as well. This is the right bronchial artery. Generally, it goes along the truncus intermedius, or right main bronchus. So it's good this is the right bronchial artery, which is just going beneath the esophagus arch. So it's possible we can preserve that. That will cause prevent for some of the possible ischemia to the carina, also the right truncus intermedius. So this is good habit. We can clean the lymph nodes, but at the same time, this right bronchial artery is being preserved. So if possible, if not embedded with the tumor, if it's possible, it's better to preserve it. Then regarding the thoracic duct injury, sometimes during the surgery, we are not intentionally trying to make the hole inside the thoracic duct. If the nodes are there, indeed, we can take it out. But if not, our practice is not to take out the thoracic duct. There was the lymph node here. So I was trying to take out the lymph node and I made a hole in the thoracic duct. You can see here, there's the hole in the thoracic duct. Nothing to worry about at the end of the surgery. After clearance, you can just put a clip over the thoracic and that's it. So anyway, we are going to clip it. It depends upon the surgeon to surgeon. If you wish, you can preserve it. If you not, you can even take it out. They're one of the examples of the complications during the surgery. There was the patient after the chemo radiation, the gross disease was there. During the surgery, there was a lot of lymph nodes. The lymph nodes, the tumor, this is the aorta posteriorly. It was very difficult in finding the pain because of the desmoplastic reaction with the aorta. So during the dissection, I made a hole into the aorta. Oh, sorry. Yeah, so I made a hole into the aorta. So again, in such cases, if you wish to, sorry. So if you wish to convert the patient, it will be even more injurious to the patient, and also it will be very difficult for the surgeon to control it. So it's better to control these things with the help of the minimally invasive surgery. You can just the Prolin suture. You can add one extra port where your assistant holds there with the Gospack, etc. You can clear. At the same time, this was the trachea, this was the left mid mucus, I assume. So I made an injury over because of the desmoplastic reaction. I made a hole inside the left mid bronchus. So you can see I will taking care with the suction. You can see here, this is the hole here. So at the same time, also converting is a big problem for the surgeon. So in those cases, you can just take a stitch. We can cover with some pleural flap, as we did in this case. We took after the closure, we covered the lesion with the pleural flap. Sometimes what happens, you can injure the superior vena cava also. At one of the patients, I injured the superior vena cava. Again, you can just put a suture and close the superior vena cava as comfortable during the minimally invasive surgery. If the pericardium is involved, there's no problem. You can excise the pericardium. So there was a big tumor here. So you can see after even the chemo radiation, there was chunk of tissue was remaining there. So pericardium was involved. So just make an incision over the pericardium incision and take out the pericardium as much as possible in order to achieve the arterial resection. It's possible. I want to emphasize that this kind of surgery is possible even for the locally advanced disease. It's not the truth that if we cannot do it with the minimally invasive surgery. I think in such cases of esophageal cancer, EMI is better than the open approach. We have the better exposure. We do not compress the heart with our hands. So that is one of the most important advantages during MIA. If we convert the patient to the open surgery, some of the assistants need to compress the lungs and also compress the heart at the same point. It may cause some cardiac injury, arrhythmia, etc. during the surgery. So this is one of the good choice during the surgery. Sometimes what happens is not very uncommon in our part. We'll see a lot of variations. We cannot create the pneumothorax in the beginning, CO2 capnothorax. So it's very good telescopic dissection like we do for the TEP repair for the groin hernia. So in the same way with telescope, we can dissect, make a plane, and with the grasp will just tease the lungs so that we can create a field where we can then work with. Sometimes we can cause the injury to the lung. So in such cases, we can just use a gauze swab like this one. We can sweep out all the structures, lungs towards your side. So that will somehow minimize the injury. So these were some of the cases that I wanted to show you. So now next, sorry. Yeah. So if some of the surgeon wants to avoid the routine clipping of the thoracic duct, there may be a question, how do you recognize the thoracic duct during the surgery? So there are certain principles you can visualize it very clearly in the surgery, or you can do a ICG test, some dye test beforehand. I mean, in the morning of the surgery, you can inject the ICG dye in the groin, then you can detect the thoracic duct during the surgery. So in this particular patient, this should be the esophagus region. This is the esophagus vein. We just made the pleural cut here. Then at some point you will see once you change the light to infrared, right? We can see the green dye here, right? It's very well seen. So then we can see that this is that we can recognize the thoracic duct, or we can go away from the thoracic duct. So in this way, you can even prevent the thoracic duct injury. It can be seen by the visual inspection also, but for better identification, you can have this, the ICG dye can be used in this such cases. Sorry. Okay, then after the thoracic part, we go for the laparoscopic part. So our routine practice is to do in the V fashion. So at umbilicus, a little bit up from the umbilicus, you make the incision. I mean, you put the umbilical port, and then you go in this 5 trocars are inserted in this fashion. Then at the end of the gastric, I will not be showing the laparoscopic part of the gastric mobilization because of the constraint of the time. And at the end of the gastric mobilization, we use the mini laparotomy about 3-4 centimeters the length here, and then for retrieval of the specimen. Then after that, the specimen retrieved from the abdominal cavity, we can see this is the stomach. Whole of the esophagus has been excised here, and we try to make a 4 centimeter wide, not very wide, not very narrow, about 4 centimeter width of the esophageal diameter. Sorry, the gastric diameter should be remaining. Then we can measure with the scale also for objectification, and we can check whether the tip of the stomach can reach easily to the neck. This is the neck part of the esophagus here, and that's the chest, that's the abdominal part. Then we can test it with the ICG angiography also. In our institution, it's our routine practice to do the ICG angiography before making the anastomosis in order to establish where is the good point of vascularization. So ICG was given, we can see the ICG is now being shown here, seen here. It's very well, and you can reach up to the tip. So where is the good vascular point, we can choose that point for the anastomosis, just in order to avoid the possible risk of the anastomotic leakage. So at the last, we make the neck incision like shown here, and we make the anastomosis either hamstring or staple. And this is the picture of the gastric lap mobilization at the end of the surgery. So now there are some of the post-operative complications. I think making the surgery may not be very fantastic, a good fantasy for the surgeon. What happens when we make the error during the surgery, when the complications happen after the surgery? It is our job to tackle. Unless we don't have the complications, I think we cannot learn a better surgery, good quality of the surgery. Let's take a few examples. This was a 71 years female, squamous cell C of the mid-third of the esophagectomy. We did the VATS filled esophagectomy. In the first, second, third postoperative day, patient was improving. Just drainage was serosanguous, no fever, no tachycardia. In the fourth postoperative day, there was the pus discharge from the right chest tube. Plain CT was done with the oral contrast. we showed the contrast leakage into the pleural space. Remember, this patient underwent the McQueen's esophagectomy with anastomosis in the neck, but he had got the contrast leakage in the chest cavity. Here is the picture we can see here. So this is the oral contrast here in the gastric conduit. It has leaked is the white material. This is the chest tube. It was leaking like this in the chest cavity. So there is no option. So with the presumptive diagnosis of the anastomosal leakage into the pleural space, the upper GI endoscopy was done and re-exploration under GU was done. We found during endoscopy the necrosis of the gastric conduit over 4-5 centimeter distal segment from the anastomos in the pulled up gastric conduit. So this was the endoscopic picture of the same patient. So we can see the mucosal ischemia here. This is all the gangrenous part, necrotic part of the, you see? So a lot of, this was the anastomosis. So in that case, we took the patient for the surgery and sorry, there's no picture. Sorry, just a moment. Yeah. So then we took the patient for the surgery.
Case, the neck was open. So we have reapproximated the medial margin. Medial margin. So
here we can see in the same patient. So we excite the necrotic part. There was a lot of necrotic part. We took the necrotic part here and we excite the necrotic part. And then we re-anastomosis, we pulled up the stomach again into the neck, and then we made the anastomosis, gastroesophageal anastomosis again in the neck. So that is possible if possible, because otherwise we have to end up with the gastrostoma and the esophagostoma, which may be very troublesome for the patient. So let's take another example. Recently, we had the 45 years male patient with complete dysphagia since last 35 days. He presented to us in pre-renal failure. It was quite dehydrated. He had hyperuricemia and thrombocytosis. The OGD was done, which showed tight, not negotiable stricture at 26 centimeter from the incisors. The dilatation was attempted, but it failed. The biopsy was taken twice. It was inconclusive. We can see the CT scan picture of this patient. We can see is the trachea. The tumor is here. The trachea has been pushed at the membranous portion here. And there is also, we can see here the lymph nodes in this picture. So this makes us confusion, but we take I think we should judge ourselves also. We didn't have a preoperative diagnosis of what to do next. We tried for the biopsy, all which was negative, and the patient was in complete dysphagia. After some of the establishment, after stabilization of the patient condition, taking down the urea and creatinine, building up the patient, then we decided to take the patient for the surgery. Before surgery, the bronchoscopy was done. At this point, we can see the membranous part of the trachea, the posterior part was pushed. It was not invaded, it was very well moving. So there was the external compression of the distal trachea, which was noted during the bronchoscopy of this patient. We did the VATS esophagectomy. All the tumor with the artery resection was done. Good specimen is shipped. Now, on first post-op day, the patient had bilateral pneumothorax. This patient had actually, during the surgery, too many of the blephs and bulla in the upper lobe. So we suspected maybe the bulla had ruptured. So that caused the pneumothorax. But it could have been the right side. Why in the left side? We didn't have an answer for that. But the left side pneumo was resolved in 1 day of time. Right-sided pneumo, after suctioning and putting in the suction tube, it resolved, partially resolved, not complete expansion, but 2/3 of the lung was expanded. Then, as per our routine, meanwhile, the patient was stable, no tachycardia, no fever. He was being fed through the feeding jejunostomy tube. As a practice from our institution, on the 7th post-op day, we do the routine endoscopy to judge what's happening with the neck anastomosis. So during the endoscopy, we found the anastomy grade 2 ischemia with partial rupture dehiscence of the anastomosis. And during endoscopy, the patient developed more pneumo. So the pneumo increased in the right side of the chest. And ear leak, which was not present earlier, ear leak happened to increase from the right side of the drain tube. So the patient was taken up for the surgery. So this is a short video of the same patient. We can see this is the endoscopy we did. We could visualize the dehiscence there. And we did the bronchoscopy also. I will pause it. In the bronchoscopy, we can see there is something is being seen in the distal part of the trachea going towards the left main bronchus. But we did not realize, we thought this could be because of the intubation. Patient might have some endotracheal injury of the trachea and left main bronchus. Though this was a single limb tube intubation, but there was something we just ignored it because we are not in a process of knowing what's happening with the patient. We didn't realize what's the major issue in that patient. Then we continued. Then after that, we decided to convert open up the patient, to take the patient to the theater. In the theater, we approached with a minimally invasive approach. Because the anastomosis was located in the neck, the patient was put in the supine position, not in the prone position. After clearing all the stuff there, this was from the supine position, not in the prone or semi-prone position. So we cleaned up everything. We found the anastomotic dehiscence. Then we could not reach up to the part where is the ear leaking from. Then we changed the position of the patient. We took the patient again in the previous position, like in the semi-prone, the position which we used to do during the minimally invasive surgery. And we found in the left main bronchus, there was a big hole here. We can see the left main bronchial injury. So this is not this time of injury. This had happened during the previous surgery, which we did not recognize. So in this case also, we suture with the PDA suture. The PDA suture was taken. And we at the end, we checked with the tightness of the suture. I mean, the completeness of the suture, completeness of the suture of the left main bronchus. So we did the positive test. There was no ear leakage that we came out from this one. So now after that, I went through the video of his surgery, which we had done 7 days ago. This is the video of the same patient. Then I reviewed because this injury had happened during the surgery, which we did not realize actually. So now our whole team reviewed this video. At one point, because of dense adhesion and also dense adhesion of this was the left main bronchus. This is the tumor is here. There is there's the cross adhesions here with the left main bronchus. I was using the bipolar cautery. Gently, it means not much of the coagulation force was there, not much of the mechanical force was there. I tried to cut it with the scissors. The scissor was of not good quality, so it did not help. Then I took the cautery monopolar hook, then I divided it. So far, we didn't see any of the injury to the left main bronchus. So now I took the cautery. It looks everything is good. Now I was again trying, maybe I was also afraid maybe I'm going to injure the left main bronchus. We were cautious about this, but we eventually completed the surgery. After each surgery, our practice is to check for the ear leakage. So we still pour the water inside the chest cavity. We checked for the ear leakage. Then let's see, there is some bubbles coming from somewhere. You see, there is the bubbles coming from. The thing was that this patient had the opening of the contralateral pleura also. And I thought that because he has got the bleps in the right side, maybe he has got the bleps in the left side also. I didn't pay much attention. I thought this is just the CO2, which had entered in the contralateral chest cavity, it's just coming there. So realizing there is no leakage from the major tracheobronchial tree, as per the description in this picture, we close. But actually, I think that was the point where the bronchial injury happened during the first surgery. So this is the learning point. I mean, we should be very cautious during the dissection in such patient. So what I say is, I just make a point which was said by a statement done by a French vascular surgeon, with the René Léris, by which we have the aorto-occlusive arterial disease. He was very popular for that. He said that history is for every esophageal surgeon that little cemetery of memories where he goes to seek the lessons of his or her mistakes. I think we had committed a mistake. We realized it. We did not realize during the surgery, but it should be our practice to review the video if we have got what mistakes we had done during the surgery. So though we did not realize, I think from next days, next surgery, we should be very cautious. We should even for the minor ear leakage that is present during the surgery. So our future perspective would be the refining MIS, ERAS protocols will be there, better integration of multimodality treatment, personalized surgical approach, improved imaging and navigation system, AI-driven some planning and biomarker-driven biomarker-driven treatment approaches. So my key message would be the thorough pre-op assessment should be there. The optimal patient positioning should be there. The port placement should be optimal because that will create some ergonomic problem for you. And the TME, I mean, total mesoesophageal excision with two-field lymphadenectomy should be the gold standard. Gastric conduit prep, anastomotic techniques may vary, but our practice is to the staple, tri-staple technique, the ES protocol, and multimodality treatment. So thank you very much. And if you wish, we welcome to our institution. If any question, any comments, I will be happy to answer. Dr. Kumar, the whole team, sorry. Come on, wait. Ask all to you can unmute all yourself.
So am I audible?
Yeah, sure.
So we have changed the class. That's why we have problem in projection. That we here first residents of surgery first year, second year, third year, as well as consultant are here. And we have got many more information about esophageal surgery. And anyone? So what is the protocol? Is there any protocol for screening in those cancer esophagus?
Sorry?
Any screening protocol?
I think we don't have a screening protocol. You mean for the esophageal cancer?
Yes, sir.
Oh, we don't have the protocol for the screening of the esophageal cancer so far. I think it's not. Can other people mute themselves? Sorry, can other people mute themselves except Dr. Kumar? I think he's asking the question. We don't have the screening protocol. Do you have in your center? Then you can recommend also.
Hello. What about this? Sorry.
Hello.
Yeah.
So what about the endoscopic mucosal or submucosal resection? What are the criteria for that?
There are certain criteria. So we can decide to do the EMR or EST. We don't have the facility of EST at our center, but we see the smaller lesion. Even the Japanese are being doing up to 5 centimeter. If not circumferential, if you can excise it with the EST, that's the best approach to me, I think. But if not, then we can do with the EMR, that's the smear polypectomy. So it is possible if the polypoidal lesion is there, then we can inject in submucosal plane some methylene blue containing solution to raise the lesion up. Then we can catch with the snare polypectomy snare and excise it. That's principle EMR. So we are not encountering those early cases of the esophageal cancer by this way. But indeed, if there is a polypoidal lesion, it's possible. We have done the polyps by EMR, but that turned out not to be malignant. That turned out to be some dysplasia or something simple polyp, benign polyps, not the malignant ones. So far we don't have any experience with the EST because we don't have this instrument available. Yes, Dr. Azhar, do you have anything to ask?
Yeah. Good morning, sir.
Good morning.
I'm Dr. Azhar from AIMS Patna, Bihar.
Oh, nice to
Just a small comment, sir. What we do whenever any tracheal airway injury occurs, then in that situation, whenever we are making a conduit, then we give more bulk of momentum and stitch it to the posterior wall of conduit so that it goes in the thorax and mechanically blocks that rent which has happened in the trachea. So that works a lot. It's just a small comment, sir. Just I wanted to add.
Thank you very much. I think this is good practice. I think that can be done. That can be practiced very well. Thank you for your suggestion.
Thank you. A lot of thanks.
Any more comments? Any suggestions from anybody? Our residents, do you want to have some questions, some comments? Anything that you need clarification about or something you can add on? Dr. Kumar, are you here with us?
Sir, regarding the screening, sir, there is ESMO has put on the guidelines that if there is a new onset of dysphagia, and if the patient has upper GI bleed, and if there is weight loss, and if there is decreased appetite, they advise for endoscopy for the screening purpose. And another is for Barrett's esophagus. If the patient has Barrett's esophagus, they also advise for the screening, endoscopic screening of.
Oh, that's very good point, Dr. Kumar, you have raised. Thank you very much for your suggestion. I think that is the guidelines that I'm going to put. I mean to say that we at our institution do not have a screening protocol for the esophageal cancer. That's true. If somebody will have the suspicion on those criteria that I've set, if the patient has a history of Barrett's esophagus or new onset of dysphagia, weight loss, etc., definitely those patients need endoscopy. That's very good point. I think for juniors, you should remember which patient require the endoscopy, how to screen those patients. But I mean to say that there's no routine or protocol for esophageal cancer screening. I think in our country, we don't have that. Like we do with the mammography, or we do for the prostate cancer with the PSA, cervical cancer screening with VIA, villi. We don't have a nationwide protocol, I think that. But it's a good point. I think we should remember those patients, we should suspect esophageal cancer, and we should do screening, more emphasis on those patients. That's good. That's a good point.
So if the patient tumor is completely regressed by the neoadjuvant therapy, either is the squamous or adenocarcinoma, and what shall we do? Either we go for surgery if there is still tumor, or we go on surveillance. What is the protocol over this?
And that's true. So what we do, because of the financial constraints, we ask every patient in those scenarios, we do the chemoradiation. Now we find by CT scan, endoscopy, that the patient has got complete response. Then we suggest the patient, can you go for the PET scan? If they say yes, then we advise the patient for the PET scan. If complete response, we recommend that you can be under close surveillance without the surgery. So I still remember 15 years ago, young man, he was at that time, I think 30 years of age. He came with esophageal cancer, very locally advanced. I think that was stage 3 patient, T4 lesion, N+, and he was treated with the chemo radiation. At those days, then after neoadjuvant, the practice was routine surgery. I advised the surgery, he refused. Now he's still under follow-up. I mean, he still comes maybe one time in 3-4 years or 2 years. He was under routine follow-up till 10 years of the time. He's still surviving without the disease. So I think there is good point. If we advise the patient for the PET scan, what the evidence says, then we can keep on the follow-up, I mean surveillance. If the patient cannot go for the PET scan, then we individualize the patient. If there is the stricture related to the radiation, maybe quite a lot of times what happens, the tumor heals, but there is the stricture which is not dilatable. So in those cases, we still consider for the surgery. Or if the patient is doubtful cases, by the CT scan, because there may be the response by endoscopy. There may be the response in the CT scan of the primary tumor, but there may not be the response to the lymph nodes, which may not be picked up by the CT scan very well. So in those cases, it's person to person, depending on his general fitness and also his desire to get into follow-up or to get the operated on. So we give the decision to the patient. If we do not go, if you cannot go for the PET scan, then you can choose either to remain under surveillance, or in the most of the patients, we advise for the surgery in those cases. So that's how we are doing it.
So other is at the esophagus gastric anastomosis at the cervical site, we have encountered a lot of stenosis in post-op period. Is there any technique to avoid that?
So right now, that's a very good point. I think the best way that you don't do the circular staple in the neck, because that causes more stricture. There are some of the patients, I mean, some of the surgeons, even myself also, initial career, we used to do the circular anastomosis through the neck. That requires a longer longer stomach to be pulled up into the neck, and that causes more stricture. The second thing is that the best way is to do the tri-staple anastomy that we have been practiced now. That seldom causes the stricture. The Odinger's technique of the stapling technique is quite cumbersome. We practiced for a quite bit of time, maybe 25-30 patients we did with the Odinger's technique. Then I gave up because that was quite cumbersome. So right now, the tri-staple technique is very fast, very convenient, and no stricture. There may be the leak, but that doesn't cause the stricture because the anastomosis is quite wide. So I recommend that you can go with the tri-staple technique that is designed to not only to decrease the anastomotic leak, but also to decrease the incidence of post-surgery stricture.
So is there any rule of NGT to avoid this stricture? If you could keep the NGT for a long time, like
I don't think so. I don't think the NG2 will be held, because if the stricture is to happen, it will happen. The NG2 will be 16 frames or 18 frames. That's how I think in long run he can swallow the liquids, but not the solid phase. So as far as the dilatation is concerned, yes, that may help for dilatation. But I think in those cases you have to start with the early dilatation. In 1 month of time you can start the dilatation. But I think keeping the NG2 for such a long time, for 1 month duration or 2 months, may not be very good for the patient. He may go into the aspiration, may have injuries to the oral cavity, may not be well tolerated by the patient. So our routine practice is to remove the NG2 by 7 days. Unless the patient has the anastomotic leak, then that's another issue. I'm not in very favor of keeping the NG2 for the dilatation purpose.
Any question? Questions? Vijay, please. Questions, sir? So thank you, sir, for your informative presentation.
Thank you very much. So we can be in touch. So next time also we can have some discussions. I don't know your group, what they are interested basically in.
Next time.
I mean, besides the esophagus, lungs, are they interested? Because we have been carrying out a lot of things right now in the lungs. With the segmental, you can have, I think for the residents or for juniors who are there, we have got the YouTube channel. This is called BPKMCH. I will share in the group, so you can have a look into that. Maybe beneficial, interesting for them, and also we can discuss those topics also during our live webinar.
Okay, sir.
So, okay, thank you very much.
Thank you, sir. Thank you, sir.
Stop by. Why?